say hey to everybody. Hi. I actually can cut this part off. Okay, let's look at the assessment of the trauma patient. You know, last day we looked at, what were the parts of our checkoff sheet that we looked at? Scene size up, exactly. We went all the way through the scene size up. So what comes after scene size up? Primary assessment. We did primary assessment, didn't we? Yeah, y'all forgot that part. We've done primary assessment. So now we're moving into our history taking and the rest of our stuff. So this presentation is not going to mirror exactly your checkoff sheets, but this is going to color in the parts of your checkoff sheets so that you'll know what you're looking at. So our trauma assessment is going to be a little bit different than our medical assessment when you think about it. How are you going to gather information, say, from a patient that has had, say, chest pain? Different than somebody that has a trauma. Say you're unconscious because somebody stabbed you, right? That's your patient, not unconscious. How are you going to do an assessment on them? By asking a bunch of questions? No, because why? They can't answer that. Okay, but over here, I've got Reed who's got chest pain. How am I going to get that information?
So I have a history of one of them?
I'm going to talk to you, aren't I? I'm going to have to do an interview with you. So with the trauma, most of the time you can see what's going on with your patient. And you can see blood all over. You know, you can see a stab wound. You know, you can see an angulated, broken area. You can see bruise. So oftentimes with a trauma, your assessment is going to come about because of a physical assessment or something that you see. If they're unconscious, you have to do a physical assessment. You have to do it fairly quickly. If they're conscious, alert-oriented, which most of the time you're going to have with a medical, you're going to do an interview with your patient. So that's going to be your two different approaches. One is going to begin really with a physical exam, whereas your medical is going to begin with the interview exam, so to speak. So that's going to be the main difference between these two. So let's get started on our trauma assessment. We're going to be looking at the difference between the assessment procedures with a patient with no significant mechanism of injury. Remember we talked about the difference in what a significant mechanism of injury is? What would be an example of a significant mechanism of injury?
Car crash.
Do what?
Car crash, you just hit the dash or the
Yeah, bad car crash, you know, where it's very high speed. What else would be an example of a significant mechanism of injury?
falling from the
Fall. Yeah, fall from a height, certainly. So those are things where you should, part of your role is going to be to determine or project injury patterns. So we're going to be looking at significant mechanism of injury versus no significant mechanism of injury. So like if I told you I tripped on this stupid thing in the middle of the floor here and I fell over, would that be a significant mechanism of injury? No. So your focus would be different. If you had somebody that had been ejected from a car that was going 50 miles an hour and they hit a tree, what injury pattern would you expect? Everything. You'd be looking at multi-system trauma. You know, they have head injury, neck injury, you have broken ribs, internal injuries, broken legs, all sorts of things. But if I just like tripped over this stupid thing, what type of injury pattern would you expect? Yeah, stub toe, really just wherever I hit. You know, if I hit my shoulder or landed on my knee. So you kind of have a focused area that you'd be looking at if there's no significant mechanism of injury. So that's basically what we're going to be looking for here. We're going to look at how to get a good history from a patient. There are certain techniques that we're going to use that will help us get more focused on what's going on. We're also going to look at how to do a physical exam on a patient. So this really is kind of fun. One of the other things you're going to have to make sure you get is a good past medical history. Say you have a patient that was injured in a car wreck and they hit their head fairly significantly, and in the history you find out that they've had prior stroke and they're taking blood thinners. Now, what is that? Does that ring any bells for you? Can you see that being a problem? What would that be? Yeah, you worry about a significant bleeding in the head. So if they've got a combination of some past medical history plus whatever's happened to them, that may lead you down a different path. We're going to look at how to do a rapid trauma assessment. You've got a patient with a lot of things going on. You know, we're going to do our primary assessment, right, our ABCs, but we're also got to see if there's anything else that could kill your patient. That's what a rapid trauma assessment is. And then we're going to look at a detailed physical exam for a trauma patient. We've got a lot of things going on here. Now, if you look on your sheets, you'll see the secondary assessment of the trauma patient. So we're going to be focusing on that right now. We will look at the segue into that portion a little bit later. But right now, I want to talk about getting a focused history and a physical exam. If you see the orders these are, we're doing focus history. What's that? That's where you're focusing on something, usually your patient's chief complaint. And then we're going to be looking at our physical exam. Usually when we do a focus history, we're looking at a patient with one specific complaint. This is not your multi-system trauma. This is like, my chest hurts. And we're going to focus on chest. Or I twisted my ankle. We're going to focus on an ankle. That's what a focused history is going to be. And we may do a focused exam also. But usually we're focusing on whatever the patient says is their chief complaint. Okay, first let's look at a patient with no significant mechanism of injury. This is where if we look at the list of significant injury patterns, this is something that's not going to be all that big a deal. You know, somebody just fell out of their chair, you know, done fell out, then you wouldn't expect a significant mechanism of injury. Usually this is where your patient tells you where it hurts. Miss Jones, you called 911 because you fell? Yes. Well, tell me what happened. Well, I'm sitting in my chair and I reached over because my cat ran by and I fell out of the chair and I laid it on my shoulder. Okay, well, can you show me where it hurts? Well, it hurts right here. So we're going to do a focused assessment. We're going to ask her about the pain in your shoulder. Well, tell me what it feels like. Oh, it just aches all over. You know, did you feel like you broke anything? No, I don't think so. You didn't hear anything break? No, I don't think so. So that's going to be focusing on the area where the patient tells you that it's painful, or if there's a mechanism of injury, the mechanism of injury indicates, you know, if they say they fell and they landed on their shoulder, then I'm going to expect what? Shoulder pain? Y'all don't be shy. The chief complaint is going to be why the patient called 911. And usually that matches up. Sometimes it doesn't. If you had several injuries on your body, which one are you going to complain about? If I said, tell me what's wrong. The one that hurts the most. Does the one that hurts the most, is that always the most serious one? No. If you've ever had like an ingrown toenail or an earache or something like that, those things can hurt really bad, but they're not going to kill you, right? So here we really want to be looking for what's going to kill you. But the chief complaint is going to be why the patient called EMS. Now, we may determine that they have something else going on, but chief complaint specifically is why they called. History of present illness. I love this. History of present illness is going to describe for you the history of that event, whether it's a medical or a trauma. History of present illness is, tell me what's going on right now. How did we get to this point? With trauma, we're looking at the nature of the force, what caused the injury. If it was an ejection, if you fell off a ladder, that sort of thing. Whatever the force was that caused the injury. The direction or the strength of the force. You know, if you hit, remember we talked about that, if you hit a tree and they're ejected, if they just like fell out the window versus if they were thrown 50 or 75 feet, then you may have a more significant mechanism of injury here. We talked about coming out of an airplane or off the what do you call it, the hang glider, and landing in the sand. You know, if you hit like this, you're looking for injuries that goes up the body versus, you know, broken wrist and that sort of thing. Protective equipment used by the patient, what might that be? Sure, a helmet if you're skateboarding or bicycle riding. What else? Seat belt, yeah. You want to note that because that's going to change the injury patterns, right? You hope. Actions taken to prevent or minimize injury. Sometimes patients may have done something else. They may have taken medication to alleviate the pain. So you always want to find out if they've done anything to change. Areas of pain and injuries resulting from the incident. That's what you want to find out too. Tell me where it hurts. Does it hurt anywhere else? Sometimes they may not even feel the pain at all, and they're not going to notice it until you start palpating it. On your physical exam, do you notice here anything specifically that they've done? They've cut those pants, yeah, and look, they didn't cut it up the seam. Oh, I'm so sorry. They just cut those pants. You're really not going to be able to do a good physical exam unless you have access to it. So we call that expose or exposure. So you're going to have to be able to feel it as well as see it. If you can't see it, you may miss something very important. You want to assess the area depending on where they tell you it was injured or where it hurts. Usually the mechanism of injury will tell you where you're going to need to examine in most cases. We're going to inspect. What does that mean? Look, palpate, touch, auscultation is listen. Yeah, so we're really looking at look, listen, and feel, right? That's kind of easy. Are we going to auscultate this kneecap? Please no, let's not. What would you auscultate? Lungs, chest, yeah. We don't auscultate vowels in here, so don't do it. Okay, when you're doing your physical exam, when I mentioned inspection, that's going to be looking. So say you have a patient with a chest injury. What would you be looking for? Well, symmetry, yeah, equal rise and fall. If they've got a stab wound over here somewhere, then you may not see that side of the chest move. If they've been hit by a baseball bat over here, and they've got several broken ribs, have y'all read that part, what that's called? Broken several ribs, where you've got some little free-floating ribs in there. Talking about paradoxical motion, or we call that a flail segment, where many parts, where the bones, the ribs have been broken off, and so they're not attached anywhere. So, you know, in order for us to get negative pressure in the chest, when you breathe in, your chest does what? In or out? Yeah, it expands. Well, if you've got a broken area in there that's not being pulled with everything else, and you're going, that negative pressure, what's going to happen to that little segment? It's going to suck in. So you've got paradoxical motion. Paradox means something appears opposite to what it would seem to be. So paradoxical motion would indicate to you that you've lost some negative pressure in there and you had broken segments of the rib. You'd also look for color. What color are we talking about? Yeah. We're looking for maybe, is it bruised? Shape, also we talked about paradoxical motion, but also if you've got a patient that's, say, broken an ankle or a bone, or they have an angulation or something like that, that might be shape, then you want to see if the patient's able to move it. Sometimes we'll do that. So inspection, these are some of the things that you're looking for. We'll talk more about some of those later too. You'll be feeling for, you know, you may not see paradoxical motion, but as soon as you put your hands on their chest and say, take a deep breath for me, then you'll feel that paradoxical motion. So it's important that you feel it. So that would be an abnormality in shape. Or if you were palpating very gently an ankle, you may feel that it's angulated or something. The temperature, what would temperature indicate to you? Yeah, if you had, say, I fell, and, you know, on the steps out here, and I twisted my knee real bad, and you palpated my right leg, and it was nice and warm, you felt a nice pulse. You palpated my left leg, and you didn't feel a pulse, and it was really cold down there. Yeah, I've got some circulatory compromise and maybe some nervous compromise there. So you're going to be feeling for temperature to see if it's the same throughout the body. Texture, what does that mean? What do you think? Texture with an injury. That's a tough one because normally your texture is going to be, you know, pretty much the same. But there's something called subcutaneous emphysema. Have y'all read that one yet? Let me write it on the board here. You have to play with this thing. All right. Subcutaneous who can tell me what that is? How fast can you look that up in your book? All right, what's subcutaneous mean? under the skin. Emphysema has to do with air, breathing. What happens with subcutaneous emphysema is somewhere in the airway tract, there's been a compromise, and air actually escapes from the airway and gets under the skin. Have you ever seen subcutaneous emphysema? No? It gets under the skin, and if you palpate it, it feels and looks and sounds like little Rice Krispie crackles under the skin. It looks like you've been stung by 1,000 bees, and if you mash on it, it kind of snaps and pops. It's pretty weird. But all that is air that's moved out of the respiratory tract, and it's moved up under the skin somewhere. So that would be a texture. It also might be a sensation. You may feel that, or you feel the sensation, not necessarily your patient feeling the sensation. How about that? You may also be checking to see if your patient feels that sensation. If you're checking their feet, wiggle your toes, can you feel this? So you're seeing if they have sensation also. Auscultation, mainly you're going to be listening for absent or decreased breath sounds. And you're going to check that in all quadrants. Remember in lab the other night we were listening, high and low, because depending on what the compromise is, you may not hear lung sounds in one of those areas. When the lungs collapse, depending on if it's a large insult or a small insult, if it's something small, then that lung may actually collapse very slowly. It may start at the bottom and collapse, and it may not move further, but if you get an increase in pressure in the chest, then it's going to go ahead and collapse that whole lung, and if you get a lot of pressure, then it may also collapse along the other side. So you may hear breath sounds on one side, not the other. You may hear breath sounds in 3 quadrants, but not in the bottom of one of your lungs because it's collapsed. Okay. This next part, DCAP BTLS. Did y'all read about this yet? Y'all can find that on your book. We'll talk about those. This DCAP BTLS is an acronym to help you remember all the things that you're looking for when you're doing a physical assessment. The D stands for deformities. Usually you can see those, but if you haven't exposed your patient by removing the clothing, you may miss some deformities. Contusions, what's that? Bruises. Contusions are bruises. So you're checking for bruising. Abrasions, what's that? Yeah.
Like screens.
Yeah, abrasion really is like road rash, or it's going to be a scrape. You just got a real light capillary bleed there, and they usually, clot off pretty quickly. They don't feel so good though, do they? Punctures or penetrations. These are going to be holes in the body. What could cause a puncture or penetration?
Dog bite.
The what?
A needle.
A needle, that would be one.
Dog bite.
A dog bite, yeah, put that in the puncture.
A stab.
Stab wounds. What else besides something externally?
Broken rib.
Yeah, if you had a broken rib that poked through, whether it came out of the skin or even if it then poked your rib, that would be a puncture. Certainly. What about the guy that, bites through his lip in a car wreck? Have you ever seen those? I'll bet some of you guys in here have done that, haven't you? Bit through your lip? No? Well, that's good. Patients seem to do that. Burns. So you're following here. DCAP, deformities, contusions, abrasions, punctures. B is burns. What do you think the T is? Tenderness. Yeah, when you're palpating, your patient goes, oh, that hurts. That would be some tenderness. You may want to ask your patient as you're doing a physical assessment, say, does this hurt? Can you feel this when I touch this? Does this hurt at all? And they're going, yeah, that hurts. Lacerations, what's that?
Deep cuts.
Yeah, those are a serious cut. Are lacerations straight or jagged? Do what? They can be either one, certainly. In fact, a surgical cut, that a surgeon does with his scalpel, that's a laceration. Most of our patients, they seem to get like that chevron, where they hit their head and it makes the kind of Y-shaped thing that's hard to sew up. Okay, so we got lacerations. What's the last S stand for?
Swelling.
Swelling, yeah. Swelling we may not see as readily depending on how quickly you get to the patient after their accident, after their injury. DCAT BTLS. So when you're doing your physical assessment on a patient, when you're doing it in the labs, when you're doing it on the clinicals or later on your patients, these are all the things that you're looking for, and you're really checking their whole body for these things. And I want to emphasize the importance of looking for all of these things. Don't just make an assumption, based on the mechanism of injury, because you may overlook something. I'll tell you briefly, when I was working in Pensacola, there was another crew there that ran a call to a local restaurant. It was kind of like Chili's or something like that. Y'all know Chili's here. Something like that. And it was for a young man who was unresponsive right out by the front door. And they got there, and here's this young guy. He's like 20 years old, and he's just down, and he's pulseless. And they don't know what's wrong with him. Somebody just called it in. There was a guy, unresponsive out front. So, of course, they had to go through the whole CPR thing because he didn't have a pulse, and they worked him all the way to the hospital. When they tried to intubate him, they got a lot of blood up through the tube. They went on and took him into the hospital there, and the doctor was doing a full assessment, trying to figure, they ended up calling it, but they were looking at him to see what the deal was, and he had a very small caliber gunshot wound right under the armpit here. And the crew hadn't found that. They had not done an assessment. Of course, they were busy doing CPR, but for a 20-year-old guy, they don't just go into cardiac arrest usually for no reason. But they didn't see that. The amount of blood was so small, they overlooked it. I don't want that to happen to you. That was very embarrassing for that crew. The doctor says, he's got a gunshot wound. Did you not see that? And they're going, no. So make sure you do a good assessment. You'll be surprised at things that you find sometimes. Just some pictures here. Would this be a deformity?
Yeah.
Oh, yeah. We call this a Colles fracture, where you really have two breaks here. It's pretty nasty. Example of contusion, abrasion. I love photos. Punctures, penetrations. This was about the size of the wound that kid had under his armpit. Very small amount of blood. All that blood stayed internally. Killed him. It was a drug thing. Burns, lacerations. How do you think this one happened?
Knife fight.
Yeah, maybe.
Or they did it themselves.
If you try to, just I guess going like this.
Tiger.
Do what?
A tiger.
Could be. I don't know. This looks kind of self-inflicted to me. I don't know. It looks pretty bad. Swelling. Yeah, there's a knot on there. When you look at the cause of traumatic injuries, this is just a little breakdown. You can see that by and large, falls contribute to most of your traumatic brain injuries. We call that TBI, traumatic brain injury. We'll look at that in depth a little bit later in the semester. But falls is the biggie. Motor vehicle accidents, for the most part, secondary. If you get a serious fall, but motor vehicle accidents, most of those, what are y'all doing over there? You almost dropped your beer? Is that what you said? Okay, just checking. I wish you'd wait till after class.
Recorded now.
Yeah, we see a lot of head and chest injuries that kill a lot of people, mainly from motor vehicle accidents, but a lot of head injuries due to falls. Anyway, I just threw that in there. Okay, let's look at a patient with no significant mechanism of injury. Can those people be seriously injured even though you don't see a serious mechanism of injury? Yeah, you can. It's not very likely, but we have these laid out to help guide you in making decisions, critical decision making. You may have a patient with no significant mechanism of injury. We're going to start somewhere else then. We're not going to spend, a whole lot of time on this big, hairy physical assessment. So we're going to start with our baseline vital signs. Baseline vital signs are good to have. We're going to talk about baseline more a little bit later. We talked about it last week, didn't we, in baseline vital signs. Why is it important to get a good baseline? Yep, so you can detect the trend. Are they getting better? Are they getting worse? Or are they staying the same? How many sets do you need to really get a good trend? At least 3, that's right. So to get vital signs, you're going to get other past medical history, just history in general, because that's what we do. we're going to be looking for our signs and our symptoms. Sign is going to be something objective, something that you can look at, that you can see, that you can independently verify. I can take your blood pressure. I can take that to the bank. I know I've got that. I can check your pupils. I can get all that. And when you're actually documenting this, you always want to separate these so that you put all of your signs together and all of your symptoms together. So your vital signs, if you see vomit, if you see blood, those are things that are signs that you can document. Symptoms are subjective. That's what your patient tells you. Oh, I feel dizzy. My head hurts. I've been throwing up for a week. Do you know they've been throwing up for a week? No, unless you see it, which I'd rather not see. Next acronym is going to be sample, your sample history. Acronym. The S stands for what? It's in your book. Signs and symptoms. Those things that we just got on the last screen, right? It's going to be your signs and symptoms. We're always going to start there. That's going to give us the beginning point of your patient. We need to know what their signs and symptoms are. And then we want to know their allergies. Now this is past medical history. Okay, this is not history of current illness other than signs and symptoms. Everything else is going to be past medical history pretty much. Allergies, what allergies do we want? Drug allergies? What about food allergies? Do we really care about food allergies? Unless what?
Unless they eat their food.
Yeah, unless like they're allergic to pecans and they were just eating little pecan clusters or something. They're allergic to seafood, where that could have an immediate impact on why you call 911. But for the most part, with allergies, we're looking for any medication allergies specifically, because the most common cause of an anaphylactic reaction is going to be medications, new medications typically. You want to get a list of their medications. You might even suggest to your patients, if they don't have a list written out, particularly if there are people that you feel like call 911 frequently, that they should keep a list of their medications. I recommend them to put it on the computer, get a relative to type them all out. Because you know about medications that just one letter, one or two letters can change dramatically what that medication is. So they need those written out for you. If you get a collection of their medications, you want to have somebody in your party, your crew, to write all those things down. You also want to find out which ones they're currently taking versus the ones that they're not currently taking. You know, grandma gives you a box of medications and you're thinking, oh my gosh, if you take all of those, I mean, it's going to kill you. So you have to separate out what are your current meds and what you just keep for just in case. You know, a lot of people do that, not just old people. Like probably some people in here. No, nobody does that. You do that? Yeah. Pertinent past medical history. If we get called to Reed's house, you don't mind if I put on your video? Oh, I shouldn't say your name since we're on camera, right? The gentleman with the hat in class called 911 because he has chest pain. What would be pertinent past medical history? Yeah, have you ever had this before? What did it feel like? What did they do about it? Did they put you on any medication about it? So you want to get their past medical history as it relates to their history of current illness. Now, if I'm trying to get past, if I'm asking about past medical history, he tells me he had his tonsils out when he was 5. I mean, do I care about that? No way. Because of what keyword? Yes, sir. Pertinent. As it relates to whatever it is you're checking your patient for. Pertinent past medical history. I guess I should erase that. Last oral intake. Why is that important?
When's the last time they took their medicine?
Well, that's not really what they're looking for here, but that's what they're talking. The last time they ate, but why do I care?
Because you got to do surgery.
Yeah, in the event they have to go to surgery, a lot of your patients may end up there, particularly your trauma patients. The anesthesiologist hates vomit almost as much as I do. Almost as much. But why is vomit a problem when you're unconscious? Yeah, you aspirate. So we like to know when they ate last. Personally, I want to know what they ate last because I want to know what I'm going to be looking for. You know, is it spaghetti and beer? or we just have something innocuous, you know, some peanuts or something. But anyway, you want to get their last oral intake. You want to know what it was and when it was. Now, sometimes what it was is important, really. You got a patient with a lot of nausea and vomiting, and they feel like it was from maybe something they ate. Then if you get the last oral intake, and you start quizzing them about what they had, and think, you know, maybe they got some sour milk or something. So it's important to know that. The last one is what? Events leading up. That's basically trying to find out, well, what were you doing when this started? Or is there anything you did that you feel like led to the problem? Like me, for instance, I never eat lettuce out. I don't know what they do to that lettuce. They do something, but it makes me sick as a dog. I love lettuce, but I always know if they said, well, you're throwing up and you're all sick, what do you think it is? I said, it was that lettuce I ate at blank. So I always know what that is. So, yeah, I just don't know if they don't wash it well or they put some chemical on there that just goes, hurry, you've eaten that chemical again. But I'm okay at home, so I always wash my own lettuce. But events leading up, you know, can you think of anything that happened that may have caused this? Oftentimes your patients know, and if you don't ask them, they don't tell you. Boy, we got here in a hurry.
Is asking all that necessary? Because when I mean, unless they're like actually in the ambulance, because when I called the ambulance, they didn't do like any of that.
You may not have noticed it if they didn't go like right down the list. Like, it really depends on the situation with the patient. If they twisted their ankle, I'm not probably going to ask them when they ate last because they're probably not going to have surgery. But most of the stuff you get pretty much without even thinking about it. So you just didn't observe them asking any of those questions.
Yeah, I mean they did ask me, but so I had asked them, so they did.
Oh, they asked you. Oh, I'm
Yeah.
sorry. What'd you call 911 for?
I was in class.
Were you okay?
Yeah. A woman came in, she didn't tell me the stop sign, and then I hit a tree on top of the
Oh, well, that was you.
That was me. You can see that tree right in front of I think McDonald's. Yeah, right in front of McDonald's. The first tree. If you're turned to the right to go into McDonald's, you're already in Tiger Town. Yeah, that tree, the box log on. That was me. No. She didn't stop, and she didn't mean. I was on the road. I came out from the tree.
So I guess you weren't really bad off.
No, I just have that.
Little boo-boo there. So yeah, you know, some crews do a better job than others. Some feel like, you know, it's not necessary. But for you guys, it's necessary. Just do it. It's never wrong to do it, and oftentimes you'll be glad. We're going to look briefly here at how to apply a cervical collar. We're going to be doing this in lab tomorrow night, and this is a lot easier to learn when you're actually seeing it. What do we put a cervical collar on a patient for? Yeah, if you suspect maybe a cervical spinal injury, you don't want them moving their head around. So this really, while it doesn't prevent movement, it helps to restrict movement and helps to remind the patient they don't need to be slinging their head around. But it's important that based on the mechanism of injury, you determine if you're going to need to spinal immobilize a patient. When we spinal immobilize, they get everything. It's no halvesy. You don't put a C-collar, that's a short term for cervical collar. You don't put a C-collar on them and then not put them on a long backboard. Either you do or you don't. There's no in between. And we're going to measure it to make sure we get the right size on there. So we'll be looking at that tomorrow night. But now before you put the collar on, you need to make sure you do a good physical assessment. Because once you cover that area, you don't have access to it anymore. And you won't be able to palpate it. You won't be able to see it. So you're going to need to do that before you put it on the patient. Now, how many of you guys have been spinal immobilized before? They didn't spinal immobilize you? No. None of you have ever been on a backboard?
I have, but not for a reason, just for lifeguard certification.
Oh, okay. You know what goes on there. Gee, that's interesting. We're going to have to work on you guys. You need to be like wrecks or have accidents, or we'll push some of you guys down out here.
I'm very accident prone, just give me a while.
Oh, really? Oh, gee. Well, stay away from those steps. They always scare me.
1 yard trip on your life.
But you know, when patients call 911 or when they interface with the 911 system, it's very scary. So always remember to reassure your patient. When you calm your patient down, what impact is that going to have on their vital signs? Yeah, it's gonna settle everything down, and that helps everybody. So we'll always reassure your patient. Make sure you measure and size your collar. We'll do that tomorrow night. If they've got a bunch of stuff they do, you're gonna need to move that out of the way. Like the olden days, you know, you don't do this, but women sometimes wore these big old earrings, and by the time you strap that thing on, it was very uncomfortable. Here they are. We'll look at this tomorrow night. We're also going to put on the long spine board. A patient with a significant mechanism of injury, you're going to take manual stabilization. What that means is you manually take your hands, put it on your patient, and hold their neck. In this case, we're talking about the neck. Hold that still until you can get your cervical collar on. And then you'll hold that still until you can secure them to a long spine board. Same thing, it's say they've got a ankle injury. You would hold manual stabilization on that ankle until you can get it immobilized in some type of splint. So as part of putting on your C-collar and holding manual stabilization, as soon as you've assessed the neck adequately, then you can put that C-collar on. You still have to hold on to it. And then we're going to be looking at doing a head-to-toe rapid trauma assessment. This is for what type of injury? Significant mechanism of injury. We will do a head-to-toe rapid trauma assessment. Remember at the very beginning I mentioned that we're going to talk about a rapid trauma assessment. And that's going to be different than a focused exam. Who gets a focused exam? An isolated injury, or isolated problem, just one specific thing. Okay, a rapid trauma assessment. This is after we've done, if you look on your sheets, after we've done our scene size up, after we've done our primary survey, before we do our history taking, right here where it says identifies patient priority and makes treatment transport decision based on GCS, it won't be based on that. But right in here, before you go further, is where you're going to do your rapid trauma assessment. What's the purpose of the ABCs, the primary assessment? You're assessing your ABCs, but what did you say?
If they don't have that stuff, they will die.
Yeah, you're exactly right. The purpose of the primary assessment is detect and treat any life-threatening problems. The purpose of the rapid trauma assessment is to detect any other life-threatening problems outside of ABCs. So if you had a guy with, both of his feet amputated, that might be pretty serious, depending. That you might, if you hadn't found that before, you'd find that in your rapid trauma assessment. If you had a patient, say, that had a significant hip injury, say his hips got crushed, you didn't know that just from doing your ABCs, but you do your rapid trauma assessment and you go, oh my gosh, both of his hips are crushed. How could that be life-threatening? Bleed, absolutely. He may bleed to death before, an internal bleed before anything else, before you can get him anywhere. The rapid trauma assessment is very quick. We won't demonstrate that this Wednesday, but we will next Wednesday. Unless I change things. It happens very quickly. You should be able to do it under 1 minute, more like 30 to 45 seconds. You're just looking for something else, anything else that could kill your patient. It's performed on the scene, and it will reveal anything else other than what you've already uncovered in your ABCs. Whatever care you're going to provide en route will be based on this. If you've got a significant mechanism of injury, you're going to be mostly concerned with ABCs and anything else that can kill your patient. And of course, speed. Okay, when you're doing your rapid trauma assessment, it really is almost identical to your detailed assessment, which we'll demonstrate a little bit later too, only we don't really spend any time examining the eyes, the ears, that kind of thing. You're looking on the head to see if there's been a significant trauma. You're looking at the back of the head, the neck. Is the spinal cord, does it appear to be intact? Is it straight? When you palpate it, is there any bleeding back there? Basically the decap VTLS, and you'll palpate that. You'll look at your hands and make sure there's no blood on there. You'll also look at the front of the neck. Is the trachea midline, meaning it's not off to one side or the other? Is it intact? You're looking for jugular vein distension. Remember where the jugular veins are? got one on either side of the neck here. If they are distended, you know what that means? They're engorged, they're full. Say if I'm standing up like this and you notice that I have distended neck veins, what does that mean to you?
Bad circulation.
It's what?
That's bad circulation, probably that buildup somewhere in your
Yeah, exactly right. That blood wants to come, gravity wants to bring it down to the chest area, right? It returns to the heart. If it can't return to the heart, that must mean there's already something in that space. So you may have a significant chest injury and a lot of bleeding in the chest, and it's not going to allow that blood to drain from your head. It backs up. So that may indicate that. So you'll look at those around the neck, and then you'll put your C-collar on. But you're going to check the head. You're palpating the head, right? With your little hands, you're going to touch everything on the head. I'm not talking about the face so much, but you will check here to see if the bones are intact. Or you're checking here to see if you've got, part of the skull that may have been fractured. You're going to check the chest. When you check the chest, I want you to touch the chest. If your patient's conscious, I want you to say, take a deep breath for me. That'll tell you what. When they take a deep breath and you're touching their chest, what's it going to tell you? Tell you what? Yeah, are they breathing? Are they moving enough air? What else?
Is there any paradoxical motion?
Do I have any paradoxical motion, which would be opposite, some irregular motion there? What else might it tell you?
Where is
Do what?
where is the pain?
Yeah, they may tell you, oh, that hurts when they take a deep breath. If it's sensitive or if it's tender, they may notice pain they didn't realize that they had before. You'll be feeling if the chest wall is intact. You'll be able to feel if you've got equal rise and fall. And of course, if you're touching, you want to check your hands to see if you may have blood on your hands. You may not roll them up, at that minute, stare up and down their back, but you're going to palpate as far around as you possibly can. The abdomen, what are you looking for there? Yeah, is it distended? Is it discolored? Is it tender? When you palpate it, and we'll look at how to do that a little bit later too, does it hurt anywhere? Do you see any bruising? What about if it's really firm, like you touch it, it's like rock hard in there, and they're not pregnant?
They've been working out.
You'd think that, but honestly, in most cases, if you've got, anybody, if they're relaxed, those six-pack abs are going to relax, and it should feel soft and non-tender. You should be able to palpate that. If it's very rigid, usually you're talking about a lot of blood loss, where you've got a lot of fluid that's built up in the abdomen, and it makes it very hard. What about the pelvis? You're really looking for stability. As you kind of press on the pelvic bones to see if they're stable. If they're not, you're going to feel motion there. Your patient's probably going to report some pain. But if those are broken, you can lose a lot of blood through the pelvis when it breaks. You're also going to check the back. We check the back before we put a patient on long spine board. You and a partner, usually it takes about 3 people, you'll roll them up onto the side, their uninjured side, and you'll palpate the back. You'll look and you'll feel all the way down the buttocks and the legs to see if there's that decap BTLS. And then as soon as you can, you're going to roll them onto the long spine board, and then you're ready to secure them. You're also going to check their extremities. You're feeling for decap BTLS, right? Any burns, contusions, tenderness, pain. Then after you do all this, you're going to get your baseline vital signs. So you see your baseline vital signs don't come up here at the beginning. Okay, you want to secure your ABCs before you do that. So that's going to come a little bit later. Different than your medical patient. You'll get that earlier. Make sure you look everywhere. You're looking for decap, BTLS, and anything else that's unusual. Make sure you talk to your patient. I've told you you've got to palpate. You've got to touch your patient. Some people are good with that. Some people are not. So you may have to explain to them the reason that you're doing it. I need to feel your arms. I need to check your chest to see if you have any other injuries. So make sure you talk with them so they won't be frightened. If you suspect an injury, you're going to have to expose that area. So you may have to cut open your pants or your shirt or remove something so that you can do a good examination of it. Now make sure you don't run in there and start ripping somebody's clothes off. You know, if they've got expensive clothes, I would make sure that before I cut off that $500 pair of boots, that it really needs to be done. Don't just do it because you can.
Could like someone take their, like if a family member was there, could they take their clothes off for them?
Sure. Yeah, you want to be able to cover them up after the fact, after you.
What if they have like a
complete your
bone sticking through their $500 pair of boots?
cut
I'm
it.
cutting them off.
Cut it, yeah. Sometimes you just gotta cut it. Like I mentioned, I worked with a guy that, because he could cut those things off, he would. And you just have to race him to the scene, go, Michael, don't cut those boots, don't cut that leather jacket. That guy weighs about 150 pounds more than you do, and he's about 10 inches taller. So, yeah, you know, use your own judgment here. You're going to assume that they have a spinal injury. If they've got a significant mechanism of injury, which would be the patients that you're doing this rapid trauma assessment on, you want to assume they have a spinal injury until proven otherwise. If at any time during your rapid trauma assessment you come across something that can kill your patient, you need to take care of it right then. So say you're in the middle of doing your assessment and all of a sudden, you know, your patient starts struggling to breathe. You stop whatever you're doing and you're going to go back and check on their airway. You know, if you're assessing something and you get down, you know, get to the chest and you see he's actually got a bone sticking out here or he's got a big hole in his chest, you're going to need to deal with that right then before you go any further. That's important stuff. When you're assessing the head and neck, I talked about this just a minute ago, one of the things you want to look for is if there's any cerebral spinal fluid that might be leaking from somewhere. We do something called the halo test. Anybody have any idea what that is? You looked at it, don't you? Nice try. Our halo test is really, we're just looking to separate like water or some other fluid from cerebral spinal fluid. If you dab it into a tissue of some sort, it's going to separate. Cerebral spinal fluid being thicker and then other fluids being thinner, the cerebral spinal fluid will stay tight and the other fluids will spread out, so it kind of makes like a little halo. So you can check that. With the head, you're also going to be looking at their pupils. If they got a significant head injury, you're going to be concerned about unequal pupils, right? And we'll talk about those in class. You're looking for jugular vein distension. Remember what that is? We talked about it. It will be when your jugular veins are distended or engorged. That's going to be an important thing that you want to know if they have that. And then at this point, after you've assessed the head and the neck, it's a good time to go ahead and put your C-collar on. It's not required that you put it on there, but I recommend you just go ahead and do it so you don't forget about it. Chest and abdomen. DCAT BTLS, we're looking for paradoxical motion. What is crepitation? Sounds creepy, doesn't it?
When bones rub together.
It's the sound of bones, bone ends crunching against one another. You know, if you're palpating something and you hear that little crunching sound, it's like, whoa, that's crepitation. You're listening for equal breath sounds. Now, if you've not already done this in your ABC, anytime your patient has a respiratory compromise, you're going to check breath sounds during ABCs. You should do it then. If, for whatever reason, you didn't check it then, you want to check them during your rapid trauma assessment. Anytime you got a significant mechanism of injury, you want to check them quick. You're looking for distension for the abdomen. Is it enlarged? Is it hard? You're looking for subcutaneous emphysema. Remember what that is? Okay. Yeah, air under the skin. You're assessing the chest. Well, okay, nice picture. I like that. Notice that the hands are spread out. If they're conscious, take a deep breath for me. If they're not conscious, you want to feel them breathing. They got equal rise and fall. Do you feel any bones in there? If you suspect a chest injury, what are you going to do to this guy in this picture? Cut the shirt off. Yep, shirt's coming off. Assessing the abdomen, you're going to palpate all four quadrants. When you palpate this, you're going towards the center. For example, if I'm palpating your book, this is your abdomen, I'm going to come from the outside, I'm going to roll my hand to the inside. If you see that there's an injury in one of those quadrants, you want to palpate that last. If your patient says it hurts right here, then you want to palpate that area last. If you go there first, you're going to be able to palpate the other areas. You already hurt me. You're done. So if you start someplace and go gently and work towards that, you may actually get your assessment in. The pelvis and the extremities, still look for DCAP BTLS. Priapism. Did y'all read about that in your book yet? Priapism indicates a serious spinal injury. Priapism occurs when a male's got usually a spinal injury around T6, which is going to be thoracic 6, and it's going to cause the penis to get very hard due to that a lot of blood that flows there. When you see that, you know you've got a serious spinal injury, and you need to get moving on that. Distal circulation, you're going to check PMS, pulse, motor, and sensory. I think they keep changing that acronym. Yes.
What spine you say was T6?
It's usually around T6. So it's a lower spinal injury. For priapism. PMS, pulse, motor, and sensory. It's not a female thing. You're going to check the distal circulation. Can you move this? Can you feel my fingers? Can you feel me touch this? You're checking for sensation and motor, and is there a pulse? Here we are just checking pulse, motor, and sensory. You're going to document that when you write your patient care report. You're going to document that you checked PMS, pulse, motor, and sensory. I'll usually notate that by saying PMS times 4. That means I've checked both wrists and both ankles. So it's going to be by 4. And that's a habit you need to get into because that's going to come back to bite you one day. I told you about my patient with the wooden leg, didn't I? Yeah, he had a wooden leg. So, but he covered it up. He had socks and shoes on. You know, he had his pants on. And if I hadn't seen him move that leg, I'd have never realized he had a wooden leg. So make sure you get in the habit of checking that because if you get lazy down the road, this is like way after you've left me. I take no responsibility for your laziness if that ever happens. I know it wouldn't happen to anybody here. But if you start documenting patient had pulse, motor, and sensory times 4, and the guy's got a wooden leg, who's the smart person? Not you. You look really bad. The same guy that, you know, lost a lung or whatever. And you go, he's got equal bilateral breast arm. Really? How did he do that? Or, you know, you check pupils, and pupils were equal and reactive. Oh, he's got a glass eye. So make sure you actually check that. This is checking the back. Now see, you've got somebody holding the head here. You've got 2 other people that are helping control that motion as you roll them up. And he's palpating the back. Now, not all your patients are going to be shirtless. But you can palpate this to the shirt if you need to. You can see if it's bleeding. You can feel if there's anything going on. If you suspect any type of back injury, you want to expose that. Let's see. What criteria would you use to decide whether to perform a focused exam or rapid trauma assessment? This is a short answer. Mechanism of injury. If there was a significant mechanism of injury, you're going to do a rapid trauma exam. You may have a patient that they say, I'm fine, I'm fine. But the passenger in his car, say he was driving, the passenger got killed. Would you expect a significant mechanism of injury has occurred there? Absolutely. Your patient might say, I'm fine, and he might be fine. But if there was enough force exchange that would cause the death of a passenger in the same passenger compartment, then that's a significant mechanism of injury. And you're going to do a rapid trauma exam on that patient, whether he needs it or not. Anyone with a significant mechanism of injury will have a rapid trauma assessment. Okay, kids, just briefly, kids do not require the same force to be injured that we would require. So a lesser mechanism of injury can still cause a significant damage. Remember we were talking about height of a fall? What's the considered a significant mechanism of injury for an adult fall? 20 feet or 3 times their height. How about a kid?
10 feet.
Yeah, about 10 feet or 3 times their height. So it is much less. Same thing if they get hit by a car. It's never good for anybody, but that injury will probably be more significant. with the little kid, if they're conscious and alert, you're gonna have to over-explain what's going on, because this will be new to them, I hope, and been through it a lot. Okay, your detailed physical exam, let's see, how are we doing here? How many slides have we got? Your detailed physical exam is just gonna be a slower rapid trauma assessment, except for the face. You're gonna take your time. Usually you're gonna do your detailed exam when you're en route to the hospital. On scene, what's gonna be your primary focus? Your ABCs and a rapid trauma assessment if you need that. But you're gonna stabilize your patient on scene. You're gonna take care of anything that's gonna kill them. Then in the ambulance, you're gonna take the time to do your detailed exam. This is where you're going to be doing all of your information gathering. You're going to be doing more of your interview with your patient. It's where you're going to be doing your vital signs. You're going to be palpating your entire patient, looking and seeing and all that. Your detailed physical exam will assist you if you missed anything in your primary, and then your secondary exam really is your detailed physical exam. After you've done everything else to stabilize your patient, if you have time, you do a detailed physical exam. You will also then go back and re-evaluate your primary assessment. Because your detailed exam, you're going over everything, the parts you've already done, plus the parts you haven't done. So with your detailed physical exam, it's going to start out covering the same territory as your primary assessment. Does that make sense? These are just little things you need to tuck away just to remember about your detailed exam. I'm not going to say list the 5 things listed under detailed physical exam. These are just things you just kind of need to know. It comes after all of your major interventions. When you're doing your detailed exam, you're going to have to expose your patient. Now, if they just have a twisted ankle, I don't want to hear that you've strip searched your patient, okay? Be aware of their modesty. You don't need to expose it, don't expose it. If it is an area that you do need to see, tell them what you're doing. Say, you know, I'm worried that you may have an injury here. I'm going to need to look under here, and then we'll cover you right back up. Kind of ask their permission if they're conscious and alert. So let them know what you're doing. The detailed exam is going to contain everything of your rapid trauma assessment, but you're going to do it slower and looking for other things that aren't part of things that are going to kill your patient. It's more detailed, and you're able to focus more. Okay, is it necessary to always complete a detailed assessment on a trauma patient with no significant mechanism of injury? Is it necessary? It's not necessary. I think I have the answer up here. No. It's not necessary. If you've got time for it and you've taken care of the ABCs, you've stabilized your patient, you've done everything you need to do, and you've got time, then do it. I think Ashley and I had a conversation the other day. I've had several patients where we had a long transport time and they were relatively stable, but we went on and did a full detailed assessment, and we found things that really were critical for the patient that we really didn't expect to find. There have been times where as you're doing a patient interview, after you've done your detailed assessment, and you just start asking them crazy kind of questions. I had a patient one time that I was just asking her, they said, well, do you find that you urinate a lot? She goes, yeah. I said, were you thirsty? You're always drinking a lot of fluid? Yeah, I do. I'm always thirsty. I said, well, you need to go in and, be evaluated for diabetes. Well, we ran her for a trauma, but just this kind of came up in the course of doing an assessment. And this is a girl, she obviously, from the other things, and then we checked her blood sugar too, she was a diabetic, but she'd never been diagnosed. So we did her a favor. Did it matter to our treatment of that patient? No, not really. It didn't change anything. But it didn't matter to her, hopefully in the long term, it certainly did. So sometimes you may come across something that your patient's totally unaware of that you can get them, to get the help they need. So no, it's not always necessary. And sometimes you don't have the time for it. If you're worried and focused on keeping their airway open or using the bag valve mask on them or something of that sort, you may not have time to do a detailed assessment. So It's not always necessary, but it's always nice. Let's look at the comparing these assessments real quick. I think we're getting close to this.
Yeah, how do you do a DECOM assessment if all that, and if they cannot flip over? You know, if you don't want to flip them over because you're afraid that they won't be able to.
Yeah, once you've stabilized them and you put them on a long spine board, the only time you're going to be able to assess those areas is when you turn them up and assess the back and put them on a long spine board. So you're going to do that after you've done your ABCs and really after you've done your rapid trauma assessment. And then if you are suspecting that they may have some injury on the back, then you want to have your long spine board ready and your C-collar so that when you roll them up, you can do a good assessment there and put them on the board once. You really don't want to be, if you're concerned with a spinal injury, you don't want to be rolling them up and back, up and back. You want to do it one time, check everything, and secure them to a long spine board. Did that answer your question? Okay. I can't tell. I think we're getting close to the end here. How did I get there? Comparing assessments. On a child with no significant mechanism of injury, focus on the chief complaint. Focus your physical exam on whatever they say is wrong with them. Get your baseline set of vital signs. What age do we start taking a blood pressure on a child? 3. Because why? Below that, they compensate. So their blood pressure is not going to drop until they're almost dead. So you waste time getting that. You're going to get a history on the child. And do your detailed physical exam as you go. Can you think of any reason to kind of get in the habit of doing a good detailed physical exam on a child if you're running them for a trauma? I like to do that just to see, just in the event there's some child abuse going on. You know, are there bruises? You know, are there other injuries that you may be able to detect? You know, if you got time to do it, doesn't hurt anything, and you may turn up something. An unresponsive adult with a significant mechanism of injury. Here we're talking about an unconscious guy that's been ejected from a vehicle or something of that sort. You're going to try to get a history of present illness, which is what? You'll say what? What happened here? You want to determine what the significant mechanism of injury really is. How did it happen? Did anybody see it? You're going to stabilize the head and the neck. It's going to be manual stabilization. You're going to do that in conjunction with your airway. If you come across somebody that's unconscious, you suspect a significant mechanism of injury. You're going to have your partner hold manual stabilization of the head and neck while you start managing the airway. So you'll do that simultaneously. If you've got an unresponsive adult, you want to consider calling for ALS backup. You're going to do a rapid trauma assessment. As after you secure your ABCs, you're going to do a rapid trauma assessment to see if you can determine why he's unconscious. After that, you're going to get baseline vital signs. But see, you're really not getting any history here. All of this is going to be physical assessment. All of this. History, if somebody can tell you what happened, but it's entirely possible you won't really know what happened. If you find somebody laying 50 feet from a car that hit a tree, you might assume that he was ejected. But what could be another scenario?
He got hit.
Yeah, maybe he got hit by a car. Or maybe he was laying there and the guy was driving down the road, he looked over there and saw the dead guy and ran off and hit a tree. Who knows? So sometimes you're not able to get that information. If they're unresponsive, you're probably not going to get past medical history. Where could you get some information? Possibly. If what? If there's somebody around, there's nobody around, you might look in the wallet, see if they've got a bracelet on. Yeah, see if there's anything around that might specifically tell you something. You're going to do a detailed physical exam, hopefully, after you've stabilized your patient here. Yeah, so we got here. The biggest thing is going to be recognizing the patient with a significant mechanism of injury versus a non-significant mechanism of injury, if that makes sense. With no significant mechanism of injury, you get a history of illness. You're going to do a focused exam on whatever you think is going on with your patient. Get some baseline vital signs, past medical history. If they have significant mechanism of injury, you're going to take manual stabilization, consider ALS if they're unconscious, Get whatever history you can, you're probably not gonna get much, and you're gonna do a rapid trauma assessment. We're looking for what? What's the acronym? DCAT BTLS. DCAT BTLS. You're systematically going to check the body. And this is important systematically because if you start doing it different every time, you're going to miss stuff. You need to always do it the exact same way every single time. Because when there are a lot of things going on, there are people, all over you asking you questions, whatever, if you're seen as unstable, things going on, you need to always know that when you get down to the knees, you know that you've already done all the other things. Like for me, I go all the way down the body and then I come back and do the arms. So if I'm at the knees, I know I haven't done the arms yet. Now some people will go part way down, then do the arms and catch up. Just however you do it, just do it the same way every time. Yeah?
In the book it says with kids, they say it's better to go from toes to head. Do you think that matters, or you want us to do it the same way every time?
That would be for a conscious child, and it'd be just to keep them from being frightened. If you come right at them with your hands to their face, you're going to frighten them. So if they're conscious, you're probably looking at not a serious mechanism of injury. You're probably looking at a focused assessment. With kids, we're going to be looking at their stage of development as far as your assessment. And really, so few of your patients are going to be kids. Less than 10% are going to be kids. So with your adults, you just always start the same way. With kids, if you always want to start at the toe, that's fine. If they're conscious, if they're unconscious, you start from the head and work down, like everybody else. And actually, most of your kids are going to be conscious. Okay. I missed something there. After you complete your physical assessment, go ahead and get them on the long spine board, get your vital signs. The detailed physical exam is just like your rapid trauma assessment, except what? It's slow and detailed. Yeah. Where are you going to do your detailed physical exam? On the way to the hospital. Absolutely right. A responsive trauma patient with no significant mechanism of injury will seldom require a detailed physical exam. Require there. You got time, you should get it. Use mechanism of injury. That's probably going to be one of the most important things that you do. If you've got a serious trauma, look at mechanism of injury. That will guide you as to what type of assessment you're going to do. Sometimes you got a patient that says, there's nothing wrong with me. But like I said, somebody in their car has died because it was a serious impact. So you've got a significant mechanism of injury. So you're still going to do a rapid trauma assessment on that patient. You're going to assume a spinal injury. You're going to work with at least one other medic. But oftentimes you're going to have fire department and other people there. So just try to get as much done at once as possible. Even though we say get your vital signs later on in the assessment, that doesn't mean everybody has to stand around and wait till you finish your rapid trauma assessment. No, they can be getting them on oxygen, they can be getting a blood pressure, they can be doing other stuff. So get that team approach thing going. How do the focused history and physical exam of a trauma patient with a significant mechanism of injury differ from those for a trauma patient with no significant mechanism of injury? I'm not sure what that's asking me. Yeah, skip that one. I'll cut that one out next time. Okay, you're assessing a patient who fell 3 stories. That would be from like a building. He is unresponsive and bleeding from the mouth. The driver of the ambulance is positioning the vehicle and bringing equipment to you. How do you balance the patient's need for airway control, he requires frequent suctioning, with the need to assess his injuries? Prioritize for me. Airway. Yeah, you may not be able to do anything else except manage his airway. And then you just document that. That's what you had to do.